topic now. We have another valuable friend here, Richard. Welcome.
Hi, Onur.
How are
Welcome.
you?
Thank you. How are you? So I'm
Everything
sorry,
fine?
I actually get out from the OR for a vascular injury during an ALIF, so I went to the OR, and this is why I'm late.
So,
Sorry
how is
for.
the patient now?
He's okay.
Okay, fine. So, Richard's topic is interbody fusion techniques. So, we're listening to Richard. Please go on.
Can you see my screen?
Yeah, we can see it.
Okay. So I'm. This lecture is much more humble and modest than the previous one. It's just basics about when to go for anterior lumbosacral stabilization. So I started by just giving you my philosophy on this. I will always go anterior when I change the geometry of the disc, when for some reason I'm remodeling the spine, realigning the spine, and changing the geometry of the disc. I go to L5S1 disc is if the disc is high and mobile, and if I'm going to the sacrum, and also and it's more and more important is when lumbosacral lordosis is needed to avoid misalignment. So let me I go through examples. This is typical why anterior axis is important. Look at this patient. It's a very old case where we went only posteriorly with posterolateral, probably in the 90s, went for posterolateral fixation, patient translation, everything went fine, and you can see that it fails, and we know why it fails. It fails because the anterior support is not structurally good enough, and in this case we went first anterior and replaced the screw, and this was the end of the story. Uh, it's important also to look at this posterior axis for interbody fusion. Uh, it might be not enough to restore the good alignment, and you can see in this TLIF fixation here, the lumbosacral area is still misaligned, and you can see that at the level above start to have some listhesis as a compensation mechanism. So going anterior gives you more lordosis, and also especially in patient who needs lordosis, it's a better than a TLIF procedure. So let me give you a typical example when and why I go anterior. This is a spondy by isthmic lysis at L5S1. The patient, this is a standing films, and you can see there is instability between L5 and S1. Let me take this. You can see here that on standing compared to lumbar MRI, the listhesis is more important, and we went anteriorly first after angio-CT here, where we can see clearly the arteries and the vein, and make sure that there is room for accessing the L5S1 disc here. And obviously, my main reason why I went anterior is to get not only better fusion, but the good alignment here, because this patient had a high pelvic incidence, like almost always in those lysis and those spondylolisthesis. So if I had chosen to go by a TLIF, I might be under correcting the alignment and having some junctional issue. So two reasons to go anterior. One is better, larger footprint, better fusion, and also and mainly a better alignment. And you can see here this patient had no issues, no other complication. Post-operative was comfort. So we went from this to that. So the anterior lordosis is restored by interbody fusion devices and then went posteriorly for stabilization. Let me show you how important is in term of alignment going anterior. This patient comes to me, he's 60 something, comes to me for back pain, no sciatica, just back pain. We went through rehabilitation and still complaining. I told this patient, you know, let's realign first anteriorly because his pelvic incidence is over 50, and let's realign it anteriorly and we'll go posterior in the second stage. You can see L45, L5S1. He's sportive, he's active, and I've done the angio CT here, and I decided to go by a lateral ALIF and OLIF in the same time. So this is what I've done. So I went in a lateral position, went for lateral ALIF at L5S1 here, and a lateral OLIF, pre-psoatic OLIF here to L45. So I was really surprised to see the impact of realignment. Look carefully at the patient before and look after. So look how the mechanism, compensation mechanism disappear. And mainly I want to show you the retroversion of the sacrum. This is before. Look carefully at the sacrum part here, and this is after. So you can see that from this to this, we get a better alignment and better comfort uh, at the lumbosacral area. If we look here before, look where is the retroversion here, strong retroversion before, and if we look after the surgery, you see that the pelvic parameter and the mechanism of compensation went reversed back. So it is really a strong, I would say, features when it comes to aligning the lumbosacral area. Another example where anterior axis was the absolutely disruptive solution. This lady, she's overweighted and she had L45 problem here. L5S1 at the beginning was spontaneously fused. You can see here that there is no disc, mobile disc at L5S1. She went to a surgeon who does a full laminectomy and try to fuse L4 to L5. I have no x-rays from that time, but the patient come to us after removing the posterior fixation. I don't know for which reason, and this is our patient now. So if you look here, what happens is actually by laminectomy and by trying to fuse here, he induced a kyphosis at L45. Again, L5S1 was already fused. And what happens to the patient to compensate, she dislocate L3, L4. So the patient overweighted. Her pelvic incidence is around 76, and he does a conventional laminectomy, try to decompress and to fuse. It fails, and we end up with the iatrogenic kyphotic lumbosacral area. If I go posterior in such a case, I'm not sure that I will properly align this. So what we decided to do is to go anterior first to L45, L3, L4. This is the right lateral positioning going left. This is my incision here. This is the iliac crest, and those are the two projection of the disc. So going OTP and ATP anterior to the psoas allows me to go to L45 and L3, L4, even if the disc is below the iliac crest. So this is a patient after you can see her previous scar here. So we went anterior, then posterior. And look at the results. I am almost sure that the anterior axis gave me the capability of restoring this alignment and getting, I've done a minimal invasive transmuscular fixation in the second stage. You can see the alignment here and before and after, before and after. So this is her post-op alignment, and you can see we still, it's not perfect, but at least we had an appropriate alignment at the lumbosacral area. And again, I'm almost sure today in my hands, going by a TLIF axis, even if I do osteotomies, I would say type 1 osteotomies, it won't, or type 2 won't be enough. Anterior save me and gave me the possibility of good alignment. This is a patient also who come to us for lumbar stenosis and severe back pain. This is his pre-op studies, and we went anterior for realignment and posterior what you call it, midliff fixation in a second stage. So again, it's a better, this is his post-op X-ray, and I feel more comfortable, and it's published and well known that anterior alignment generate better lordosis than posterior. So also anterior interbody fusion is an anterior structural support and might be needed every time we feel like the posterior only fixation is not enough. Look at this case here. We have done a VCR at a thoracolumbar area and realigned the patient. We were happy. This was in October 2012. We were happy, but look at the last disc. A few months later, it collapsed with some kind of dislodgement of the caudal screw. So we went from this to this. Without any breakage of the instrumentation. It was the interface between the bone and the implant fails because there is no anterior structural support. So we had to extend our fixation to the lumbosacral area. We decided to do that because a patient was on back pain and symptomatic. So from this to that, and we didn't went anteriorly here because the sacral fixation is strong enough, and we add the fusion. So this is here 3 point of fixation in the sacrum and ilium. And if you look to the CT scan, we have this amount of graft plus the screws in S1. You can see S1 in the also alar part of the sacrum and ilium part of the pelvis. So we had a strong enough fixation to avoid going anterior at L5S1 because she's a bit old. So this is my main. Technically, I would not focus on this. We know that through a TLIF uh, we can go posterior and place cage, but the restoring the lordosis is not enough. It's better to go either lateral interbody fusion or anterior interbody fusion. We won't go through why is this, what are the difference between both. But we know that lateral interbody fusion today, especially the anterior to psoas, became more popular, and we can even access L5S1. I always do angio CT especially in deformity, because you might have some anatomical difficulties, and it's important to prevent this by having this in advance. This is a native. It's the best, I would say, anterior access because you are purely supine. You can access anterior colon directly, put large footprint, and stabilize the cage in the two body. This is the cage placed here. I recommend for anterior access, technically for the young fellows, and to read this paper. It's an old paper, but it has everything in terms of anatomy and in terms of difficulties for accessing the anterior spine, from vascular to the hypogastric plexus, everything is there. The lateral interbody fusion, it's, I would say, easier. Here, this is a patient that I showed you previously. So we've done 2 levels, and you can see that opening the external oblique, internal oblique, and the transverse gives you a nice access to the psoas here. And you can see on the psoas the genitofemoral nerve, and very quickly we can retract the psoas posteriorly and get access. This is a ureter here, get access to the L5, L4-5 or L3, L4 disc. So here you can see the sympathetic chain, the ureter here, the L4-5 disc, and on the left side, sorry, on the left side here, you can see the opening of the disc and the placing the cage. In conclusion, when to go anterior? I go anterior every time that structural support is needed. I go anterior when alignment is an issue, and I go anterior when I have a pseudarthrosis and when fusion fails. Thank you for your attention.
Richard, perfect presentation. So you're doing the anterior surgeries like you're doing anterior cervical discectomy, like it's very easy. So with doing the anterior surgery, you don't need any higher osteotomies. Am I right? So
If your disc is mobile.
yeah. So when you're comparing the combined surgery and the surgeries that you're doing with the posterior high-grade osteotomies, how is the rate of the complications
For
doing the surgeries from anterior? So we know that you have less bleeding because it's like doing something. If you don't have any complication about the bleeding, you have less bleeding. About the hospital stay, I think you have less hospital stay.
Onur, you're talking about deformity cases, yes?
Yeah.
Yes. In deformity cases, my main issue is to plan my anterior alignment. I don't know if you have any thought about that, but when I have a cob angle, for example, for 10 with mobile lumbar area, I go anterior for realignment and go posterior percutaneous. But I cannot predict how much I will be good in terms of alignment by anterior axis. I like to have void in the disc. If I have air in the disc or gas in the disc, this is for me something that that push me to go anterior because the disc is mobile, empty. I go to the anterior if the cob is not severe, cob angle, and I go anterior if the posterior facets are not hypertrophic and locked. And usually I go in the concavity of the deformity. But again, I have much less complication for anterior access than from posterior access with osteotomies. Uh, I don't have a percentage to give you, but my main failure in anterior first is not aligning properly and enough the coronal views of my patient.
So another question, I think you were using the CAOPS. So you're measuring everything on the software, am I right? So how can we connect with them? I have written them a few times
Yeah.
on email.
Honor, you will have a better one soon.
Yeah. Okay. So Corinna is with us.
Hello,
Yes, hello.
Corinna.
I'm sorry, I put the wrong time zone in, so I came 1 hour. But many apologies, but I did get the end of some of your talk, Richard, which was really, really good. And I too am a very big fan of the anterior approach, so I'm glad that you spoke to those benefits. A couple questions that I had about that. One of them is actually a question from the chat. One of our participants was asking about whether or not you need and use vascular surgeons for your A-lifts. So I thought I would ask that question first for him.
No, uh, I'm a believer that first we have to have the vascular surgeon ready somewhere. And we have a convention, we have a contract with our vascular surgeon that every time we go anterior, they know that we are in such a surgery, and they came to us in immediately. But having an access surgeon every time you go anterior would be from our facilities here, even with a huge hospital, it's not so convenient. And I believe also that the spine surgeon has to access himself all complex areas. Um, so in our institution, first, and even in France, there is no anterior surgery if you don't have vascular facilities. Second, my vascular surgeons are ready to come if I have, and in 15 years, we had them 3 times. Like today, for example, I was doing my one of my senior fellow was doing an ALIF, and he calls me because he had some minor bleeding, and this is also I arrived late. Um, so no access surgeon. The access surgeon is a spine surgeon.
Interesting. I would say so at Stanford and in the United States, we pretty much always have access surgeons. And so, that kind of follows up. You were showing how you do the angio CTs, and we pretty much, never get those. And we, kind of routinely use access surgeons. I'd say also, I think medical legally kind of in the United States right now, if you don't use an access surgeon, it's a bit of a problem for us.
Oh
But
yeah, I
that's,
didn't know
yeah.
that.
Yeah, that's why I think it's always very
But
interesting to meet people internationally and see how things are in different countries. But yeah, I
yeah,
think given the state of things in the United States right now, you're very hard to defend yourself if you have a problem with an ALIF
yeah,
without a vascular surgeon
yeah.
doing the access.
We might be in this situation if I do surgery somewhere where there is no a vascular surgeon. But as far as vascular surgery is in your institution, you can go by own. And there is it looks uh, minor, but it has its importance. In the States, you can code your surgery and take into consideration that you have an access surgeon. In France, if you get an access surgeon, he has to be for free almost, or get a part of your fees. So it makes it probably more difficult in private practice to get an access surgeon every time.
Yeah, well, they do take a part of our fees. Our fees go down about half.
Ah, okay.
Yeah, yeah, yeah. We share
Good.
them. Other than so, what you mentioned you with the angio CT, obviously you can see, the blood vessels themselves, but how much do you take into account, for example, calcifications, right? Because those we can see a lot on the X-rays, and sometimes you have your older patients and you see they're completely atherosclerotic and calcified. Does that push you one way or the other? Since
Yeah.
you're your own access surgeon, I ask because for us, we don't get it. Our access surgeons pretty much go regardless of what the anatomy is. So I was just curious about that.
Yeah. It depends how important is to go anterior. If you're hesitating and you have big osteophytes, osteophytes are our enemies because it's stuck to there is some kind of inflammation, and the veins are very stuck to the osteophyte. And every time we had venal issues, it was in this situation. So if I'm hesitating and my anterior axis is minorly better, I would go posterior. But if it's important, for example, if you have a patient who had many surgery posterior and your only option is anterior, I will tell my vascular surgeon that I'm going in such a case, and either he will come and have a look once I'm on it, and especially if you want to mobilize, for example, the iliac veins, or I do it by myself. Yeah, but it's not an absolute counterindication, but you have to look at it and prepare yourself that you might have some adhesions.
Thank you. There's
Corinna, we have lots of questions to Richard. You may ask them. It's written on the right bottom here.
yeah. So one of them is if you use neuromonitoring when you performed your lateral.
No.
Um,
Because I'm anterior to the psoas, I would use intraoperative monitoring if I'm transpsoatic access, and I've done lots of them. But one of the advantage of ATP, OTP, ATP anterior to psoas is that you don't get close to the get close to the lumbosacral plexus, so you are away from the lumbosacral plexus, and I never had any injury of the lumbosacral plexus by going anterior to psoas.
and along those lines, someone was asking about femoral nerve stretching during psoas mobilization.
Yeah, I know because I go gradually to mobilize the psoas, and I stop once I get enough space for L4-5, because the femoral stretch, it's at L4-5. Do not break too much your table first, and then uh, do it gently with peanuts, retracting the psoas posteriorly. You have psoiatism, you might have some psoas pain when you flex your hip, but I never had any femoral nerve injury.
And someone also wants to know about superior hypogastric nervous plexus injuries as well.
Yeah, this is uh, I always tell my patient, inform my patient, get their consent about retrograde ejaculation, etc., etc. Um, in ALIF, uh, in lateral, there is no issue for that. For the ALIF, the risk is around 3%, and I always tell my patient that you might have, in 3% of the cases, some retrograde ejaculation. And if I feel like they are hesitating, I would not go anterior. I said, it's and if they accept, I go anterior, and technically it's always a blunt dissection. And this is also important, because if you ask an access surgeon to go to the promontorium, to the lumbosacral area, they expose with monocautery. They took a monocautery and do the hemostasis with, and this is uh, very risky for retrograde ejaculation and for hypogastric plexus injury, uh, unless your access surgeon is familiar as you to the anatomy, etc., etc. But if you take any general vascular surgeon, because they are used to go lateral for uh, for vascular surgery, they use monocautery. So no monocautery. It's always a bipolar. I would almost never cauterize till I get exposure, naked exposure, very sharp exposure of the lumbosacral area by using blunt dissection, and and that's it. So in my series, I get probably less than 2%. One was a granuloma infection, so by posterior, we went to debride him anteriorly, and it was obvious that he will get retrograde ejaculation. And I told him before he was old enough to accept this issue. And the other one was a patient in the series of lumbar disc prosthesis. He was young and he was 36 and had not complete retrograde ejaculation, but hypospermia. I don't know what you call it. It's a kind of decreased amount of ejaculation.
So, I'd like to thank Richard, Ben, and also Captain Ola. I think we had listened very beautiful, very valuable talks, and we have beautiful discussing. Any other questions?
I have one, Onur.
Please.
Richard, it's a nice presentation, really, but you are a person doing most of the interbody fusions with anterior approaches. Am I right? Do you ever use TLIF?
Yes,
Sometimes?
yes, of course, of course. Yes, yes. But I use TLF for
When?
I use next time. Ask me to talk about TLF. Especially since I have the robot, etc. It's so easy now. I use the TLF when my pelvic incidence is below. It's normal, like around 50. I go TLF. I go TLF when patient is old and I don't want to play with the vessels anteriorly. And I go also, I do my interbody fusion when I'm doing a deformity by posterior access where osteotomies are done. So I do my osteotomies and place the cage also. But I agree with you, and this is why you have this impression. I'm fan of anterior access, and my TLIF procedures drops down by, I would say, by 70%. In 10 years ago, we were all of us, we were doing so much TLIF or PLIF. And when I discover the technical, when I mastered technically the anterior access, I prefer going anterior combined with posterior if needed. But I still do, of course, TLFs. I still do also asymmetrical pliffs. If I have to correct coronal issue, I might. I've done this last week where I place pliff cages on the collapse part of the disc if I have a lateral collapse. So I learned this from Daniel Chopin, and I still do that.
Thank you. Thanks a lot. Great talks, really.
So I think we have to finish our meeting. Again, thank you so much, Richard, Ben, and Captain Olu. So hope we are going to see us in the next meeting. Thank you so much.
Thank you. Pleasure.
Yeah.
Thank you a lot.
Thank you so much.
Bye. Bye, Corinna.
Goodbye, Corinna. Goodbye, Richard.
Great to see you all.
Wish to see you again.